Good afternoon, everyone. First, thank you so much for your patience with us this afternoon, and thank you for joining us today. And without further ado, our presentation is called Advancing Health Equity Through Better Evidence for Asthma Care, and we will be presenting our equity-focused policy recommendations using the Patient-Centered Outcomes Research Institute's asthma research portfolio. So our speakers today include myself, Denise Sanchez. I'm a policy analyst at Families USA. I am accompanied by my colleague, Emmett Ruff, who is also a policy analyst here. And we're both very excited to have Dr. Jerry Krishnan from the University of Illinois at Chicago as a co-presenter here, and also Stacy Chacker, who is the Director of Policy and Practice at Health Resources in Action, and also part of the Childhood Asthma Leadership Coalition. And so our agenda today looks a little like this. We will be presenting on what is patient-centered outcomes research and why it matters. I will very briefly go over a few asthma inequities, and then I'll pass it over to my colleague, Emmett, who will be presenting the Patient-Centered Outcomes Asthma Research Portfolio, and he will be co-presenting that with Dr. Krishnan. And then we'll talk about the policy implications of this research portfolio, and then we'll talk about, Stacy will be presenting on sustainable financing for asthma services outside clinical settings. But first, I'd like you to introduce the Families USA's Center on Health Equity Action for System Transformation. We launched this center back in December 2019, and it is the only national entity exclusively dedicated to the development and advancement of patient-centered health system transformation policies designed to reduce racial, ethnic, and geographic inequities. We focus on advancing equity while improving outcomes, increasing value, and lowering costs. And we do this by catalyzing and coordinating action to develop and implement health equity-focused healthcare delivery and payment policies. And we achieve our impact by partnering with and supporting community leaders, health equity experts, and other stakeholders at national, state, and local levels. The center houses 6 different projects, but we will be speaking about one in particular today. We will be discussing the work of the Evidence for Equity Initiative. And so, as many of you know, the U.S. healthcare system is both extremely expensive and highly ineffective. To reduce costs and improve health outcomes, health system transformation efforts are increasingly rewarding and incentivizing evidence-based care and practices. To ensure these transformation efforts are equitably beneficial for all, decision makers require evidence that is representative and of diverse communities and transparent of the specific populations included in evidence generation. Excuse me. However, we know that our current evidence is incomplete and sometimes biased, and this risks the widening of racial and ethnic and other inequities. That's why the center created the Evidence for Equity Initiative, which promotes representative and transparent evidence to help decision makers implement health system transformation policies that advance health equity instead of making inequities worse. And to do this, we're very excited that we've partnered up with the Patient-Centered Outcomes Research Institute, or PCORI, to take advantage of emerging research that they're funding to inform the future direction of policy and health system transformation. So I mentioned that our evidence base is incomplete and sometimes biased. So why is that? Well, Historically, clinical and health system research has primarily relied on white young males and have tended to exclude diverse communities, including communities of color, children, women, the elderly, and people with medical complexities. But the healthcare system has long generalized the results based on a homogeneous population to apply to all, without testing if they work for these diverse populations that may have different needs. The broad generalization of incomplete results threaten to widen racial, ethnic, and other inequities. And so, for example, we know that Black and Puerto Rican children have the worst asthma outcomes, yet albuterol, the first-line treatment against an asthma attack, is less effective for them. One reason for this may be because they have been excluded from traditional research practices. So in this way is one reason how our evidence base is incomplete. Secondly, we lack patient-centered outcomes research. Outcomes that matter most to patients don't necessarily drive research. Asthma patients, for example, may want to know about the number of nights of interrupted sleep or the number of missed school days or work days that a new medication can afford them. But instead, research is driven by the interests of scientists, for the most part, in looking for biomedical findings that may not be relevant to patients' needs and daily functioning. A third point is that when diverse populations have been included, researchers don't always stratify findings by demographics like race, ethnicity, and gender that would allow for in-depth analysis. I will discuss the significance of data stratification, especially as it pertains to the uneven distribution of asthma, in a later slide. So we do have an incomplete evidence base, but there are solutions to make it more complete and to strengthen it. These include comparative effectiveness research, or CER, and patient-centered outcomes research, or PCOR. CER compares the benefits and harms of multiple interventions and significantly is interested in the variability of treatments across subgroups, including those absent from our current evidence base. CER uses real-world populations and settings that promote inclusion by diverse populations. So again, communities of color, children, those populations that have been traditionally left out of traditional research practices. And then we also have PCOR, which is CER with the patient perspective. PCOR prioritizes patient voices in research stages by meaningfully involving them in research implementation, analysis, and dissemination to improve the relevance and the quality of the evidence. These research practices, which emphasize the inclusion of subgroups and greater patient involvement, generate more representative evidence, which as a result can advance health equity. So the U.S. government, who is by far the largest public funder of biomedical research, has enacted legislation to improve our evidence. I said it's incomplete, that it lacks diversity. And so it created the Patient-Centered Outcomes Research Institute to advance the quality and relevance of evidence to inform healthcare decision-making centered on patients and subgroups. PCORI funds projects across a number of research portfolios, including asthma, to inform the development and implementation of delivery and payment reform policies. These projects emphasize particular populations, including racial and ethnic minorities, low-income communities, women, older adults, those with multiple chronic conditions, and children. So this was a very, very brief overview of how our evidence base is limited, the consequences of incomplete evidence base, and how PCOR can strengthen the evidence base and advance health equity. But if you want a more comprehensive look at these issues, you can check out our in-depth report and webinar on this topic at the Evidence for Equity Initiative website. This webinar is being recorded, so you'll be getting these links in your inbox within a week or so. All right, and now moving forward to asthma inequities. So asthma is the most common disease of childhood, but it affects children of color disproportionately. Children of color have worse outcomes than their white classmates, including in prevalence, mortality, and hospital admissions. This slide here focuses on asthma prevalence, mortality, and hospital admissions for Black children and Puerto Rican and Hispanic children. So here we have Black children are 2 times as likely to have asthma, 10 times as likely to die from asthma, and 4.5 times as likely to be hospitalized due to asthma. I've included Puerto Rican prevalence data where it was available, but as you can see, Puerto Rican mortality and hospital admissions for children isn't reported, and I will explain why that is and why that is significant in our next slide. So the previous slide focused on children, but this slide presents overall asthma rates per racial and ethnic group. Take a look at the 3 right columns where we have Hispanic, Puerto Rican, and Mexican. At the beginning, I mentioned how lack of data stratification limits the evidence base, and these columns showcase the importance of data stratification. Stratifying data is critical to understanding the variations across and within groups that allow for meaningful and tailored treatment interventions that can better address inequities. Even when race and ethnicity data are available, they are often collected, analyzed, and reported in aggregated groups. And this can mask clinically important differences among subgroups of larger categories such as Asian Americans and Latinos. Some groups are often missing altogether, and you can see here that we don't have any data information for Pacific Islanders, Native Hawaiians, American Indians, and Alaska Natives. The absence of subgroups in data used in these types of studies means that researchers cannot examine important racial and ethnic variations, making the data less relevant and useful. For example, only by separating the data on Puerto Ricans from those of other Latino populations in the U.S. was it possible to identify serious inequities in asthma prevalence, outcomes, mortality, and albuterol response. Looking at Latino data, as you see here under Hispanic, obscures the critical inequities that Puerto Ricans have the highest asthma prevalence across any ethnic or racial group. All right, and so now I'll pass it over to my colleague, Emmett Ruff, who will be presenting the research portfolio, the asthma research portfolio. So go ahead.
Thanks, Denise. Good afternoon, everyone. So as Denise mentioned, Families USA has partnered with PCORI to review 6 research studies that are all part of PCORI's asthma portfolio. And all 6 of these studies use PCOR and CER techniques, and all 6 measure the effects of care or provider interventions on asthma-related outcomes. So in terms of the availability of results, I should note that much of this research is still ongoing, but the abstracts for all 6 studies are available on PCORI's website, and we'll have a slide with links to those abstracts later on in the webinar. Most of the studies have completed their research phase, though, and some have completed peer review, and a few have published results that are publicly available. And we're expecting to see even more published results by the end of the year, and we hope to update our report and possibly have another webinar to reflect any new data that is made available later on in the year. Okay, so now I will give a quick overview of 5 of the 6 research studies, and then after that I'll turn it over to the principal investigator for the 6th research study to give us an even deeper dive. So the first study in the asthma portfolio is the BEAM study, to put it shortly. So this study focused on Black children and their parents or caregivers, specifically in Washington, D.C., and the study shows that after 12 months, stress management classes for caregivers, parents and caregivers, can reduce their children's asthma symptoms. And because the study focused specifically on Black children and their parents, which is a population that as Denise mentioned, experience asthma at a much higher rate than their white counterparts. We can say for sure that this successful and targeted intervention is effective in reducing a specific inequity that is experienced by a specific population. So this is really valuable in terms of addressing health disparities. However, this study, there is a limitation in that this study provides no direct evidence of a link between caregiver stress level and asthma symptoms. It's clear that the intervention itself is successful. However, sort of the mechanism for how it works sort of remains unclear. The researchers did not include a measure of caregiver stress level. They really only measured participation in the stress management class. So that specific connection sort of remains to be investigated. Okay, so next is the G2P study, which focused on patients from 6 community health centers in Seattle and King County, Washington. And the study shows that community health workers, or CHWs, can improve asthma-related quality of life. And so although this is a study that is still ongoing, it should also be noted that the CHW intervention and other guideline-based interventions that were measured in this study are already being shown to be effective and are already being integrated into clinics and in provider teams in the greater Washington state area. And they're being implemented as part of the state's Medicaid Section 1115 waiver. And I think this is really a great example of how a successful intervention can be implemented or expanded to a larger state level. And it's also a good example of how Medicaid can serve as a sustainable source of funding for a successful intervention. This study also has a limitation in that there is no available stratified data on the effectiveness of the intervention, and that's something that we'll get into more later on in the webinar. So our next research study is the SAMBA study, which focused on older adults in New York City. So the SAMBA intervention stands for Supporting Asthma Management Behavior in Aging Adults. And that sort of SAMBA intervention consists of meetings with CHWs in the home or meeting with asthma care coaches in a clinic setting. It also involves creation of a care plan, setting up goals, and then over the course of a year, there's follow-up meetings with either the care coaches or the CHWs. And through this study, the intervention, the SAMBA intervention was shown to improve quality of life and asthma management for Black and Latino adults. So the study focused specifically on Black and Latino adults in New York City who are over the age of 60. Okay, so the next study, I know I'm going through these pretty quickly. The next study is improving youth question asking and provider education during pediatric asthma visits. So in this study, youth who completed a question prompt list and watched an educational video prior to receiving treatment were shown to be more likely to ask questions about asthma medications, about asthma triggers, about environmental control to remediate some of the social determinants of their asthma symptoms. And providers were also shown to be more likely to educate these youth after the youth had been asked to participate in the question prompt list and the educational video. So although this study was shown to be effective, it's also limited in that the data on the effectiveness of the intervention is not stratified. Effectiveness in addressing specific inequities remains to be seen. Okay, so next study, and this is the last of the 5 that I'll be going over, is training staff at doctors' offices to use shared decision-making with patients choosing asthma treatments. And so this study compared 2 training programs to implement a shared decision-making model in primary care practices in North Carolina. So it should be noted, it's important to think about this when determining what effective evidence was generated. It should be noted that the shared decision-making intervention in this study did not result in improved asthma-related health outcomes. However, So in terms of measuring, asthma outcomes, it wasn't shown to be effective. However, researchers were also measuring or comparing two different implementation strategies. So the study does show that the intervention was successfully implemented using a 12-week facilitator-led training program. And that training program was more effective than like a single lunch and learn style program. So this is really good to know when it comes to implementing other more successful interventions. For example, something like the Samba intervention could be implemented in primary care practices using the same 12-week facilitator-led training program. Okay, so that concludes my very quick overview of the 5 of the 6 research studies. And now to go more in depth on the 6th research study, the Chicago Plan, I will turn it over to Dr. Jerry Krishnan.
Great. Thank you so much. This is Jerry Krishnan, and I was the principal investigator of this project called the Chicago Plan. The background is that the health commissioner for the city of Chicago came to my office and asked if we as health systems could work together to design and deploy and test a more efficient strategy to address the needs of children who are presenting for uncontrolled asthma. What he had seen is that as ambulances pick up children, bring them to the emergency department, in most cases children are treated and able to go home, only to come back to the same children a few weeks later and repeating the exercise. And he felt that there was a need to have a more coordinated approach to addressing this. We engaged 6 different health systems in Chicago, all of which provided a high proportion of care to African American and Latino children. Something like 90% plus of the children were either black or Latino. Most of them were actually black. And this was done in collaboration with the Chicago Department of Public Health as a way to have a public-private partnership in working on population health. We tested 3 different strategies. The first, as we call it Group 1, is that clinicians, children, caregivers were asked to complete a culturally tailored paper decision support tool in the emergency department that laid out in more easy to understand terms, what is the care that they're being given, what is the care that's being prescribed when they go home, and when their follow-up appointment needs to be, all of which are recommended by asthma guidelines, but for various reasons are incompletely implemented in emergency departments. In Group 2, we had the same culturally tailored paper decision tool, but in addition, we offered families as many as 5 home visits led by community health workers to not only assess comprehension and use of the decision support tool and the instructions therein, but also to look at the house and understand what may be some triggers in the home and essentially more fully implement the action plans that had been developed in the emergency department. And then Group 3 is usual care. We focused very much on the need to have a usual care comparator, because sometimes when you're making interventions, you think they're going to be effective, but without a control group of sorts, it's hard to know how big of an effect you get, given a particular dose of the intervention. The outcomes we looked at was the quality of care in the emergency department as it relates to guideline recommendations. We also focused a lot on self-management practices, in the caregiver and children after they leave the emergency department. The goal being that just improving the care that children receive in the emergency department is not enough, and so we need to empower and activate and support children and their caregivers when they leave. And we relied on survey responses from children and caregivers about how asthma affected their lives using validated instruments. We also used pharmacy data to look at dispensation rates and electronic health record review to look at utilization rates. So the original plan was to enroll about 640 children across the 6 hospitals. For various reasons, including the complexity of conducting projects in the emergency department, we enrolled just over half of that, about 350 children. And that proved to be an important lesson learned for all of the health systems in working with the Chicago Department of Public Health, is that the resources necessary to conduct some of these studies, particularly in the acute care setting, are actually quite substantial, and I think has provided a basis for us to conduct some future projects. What we did find, and this is the good news portion of it, is that the decision support tool dramatically improved the quality of asthma care in the emergency department, much higher concordance of the care that was received compared to guideline recommendations regarding the use of systemic corticosteroids, controller medications, and arranging follow-up visits. These were so dramatic that we all had to make sure that we did the analysis right, but double or triple essentially compared to usual care. We also found, though, that there was a dose response, and that the community health worker arm that had both the decision support tool and the home visits actually helped support children and their caregivers in terms of self-management behaviors. In essence, we found that pharmacy dispensation data indicated they were much more likely to fill prescriptions written in the emergency department with community health worker support, and also attend follow-up visits that had been scheduled, 2, 3, 4-fold what we had seen in usual care. Essentially, what we're seeing is a dose response that we need to not only focus on the providers, but also in a multi-level way help support children and their caregivers. And I think highlighted for the health systems the importance of having supports across the care continuum and not just focusing what's in the emergency department. We did not find, sadly, that we were able to reduce repeat ED visits or hospitalizations, which really was the whole basis for which we conducted the study. We did find that in all three groups, actually, so the usual care group and the 2 intervention groups, the children had better asthma health. Caregivers reported more ability to conduct their activities of daily living, and they all reported less utilization, but all three groups improved. And the importance of that is that it reinforced the need to have a control group, a usual care group, because if we had not had that, we would have concluded also that not only that the decision support tool and community health worker interventions, improve care, but also that it would have reduced, morbidity as measured by ED use and hospitalizations, which clearly without the control group, we would have erroneously concluded that. So this was an important project in that not only did we learn how to do research together in a coordinated way in Chicago, but also the importance of having rigorous study designs to be able to quantify benefits.
Thank you so much, Dr. Krishnan. I think it's really important to get the researcher side of this perspective. And if any of you are interested and want any more information on these research studies, including the Chicago plan, you can access the links that are in this slide and which will be made available after the webinar. Okay, so after reviewing these research studies, their limitations, and the evidence that they generated, we were able to make 3 overarching policy recommendations. And our first 2 policy recommendations are geared more towards future research projects with the intention of generating better evidence to identify and address health inequities. And so these are sort of based off our experience in reviewing the PCORI's asthma portfolio, both good and bad. Okay, so the first research-oriented policy recommendation is that researchers should be required to stratify their results based on race, ethnicity, gender, and sort of other demographics. And so as Denise and I had mentioned earlier, a major limitation in our evidence base is that the results of research studies are not stratified to hone in on outcomes of specific populations that experience inequities. And so this prevents these studies from developing solid evidence that can address those health inequities. And this limitation was evident actually in 3 of the 6 studies that we reviewed as part of PCORI's asthma portfolio. So, for example, studies that had interventions that were shown to be effective in reducing asthma symptoms on the whole. However, because researchers did not stratify their data for specific populations, and those specific populations being ones who disproportionately experience asthma, and these are the populations who need the interventions the most. Because they weren't stratified, we can't know for sure if the intervention is actually effective for those specific populations. And therefore, we can't say for sure if the intervention actually reduces inequities. So thinking on the other side about positive examples, I think the Chicago plan actually serves as a really positive example of effectively stratifying results. So as Dr. Krishnan said, both Black and Latino patients participated, and the results were stratified by ethnicity. So by stratifying that data, we're able to see that the decision support tool and sort of some of the other interventions were effective for both African Americans and Puerto Ricans. So the study included multiple racial and ethnic groups, but we know for sure that the intervention was effective for each of these groups and not just as a whole, because the results were stratified. So going beyond stratification, an alternative research practice that addresses inequities is to focus a study solely on a population that experiences inequities so that the results are directly applicable to that population. So, for example, as I mentioned earlier, the BEAM study focused solely on Black children and their parents who disproportionately experience asthma symptoms. And in this study, there was no real need to stratify data by race or ethnicity because it focused only on one racial or ethnic group that disproportionately experiences asthma symptoms. So now through this study, we know that the particular intervention is effective in reducing asthma symptoms among this particular population, that being Black children and their parents. Okay, so our next policy recommendation, also sort of research-oriented, is that qualitative data from parents should be included in research studies that focus on children, and particularly studies that focus on children of color. So 2 of the research studies in this asthma portfolio and discussed in this webinar focus specifically on children of color. And by comparing these 2 studies, we can make an important distinction in how evidence is generated. So using the Chicago plan again as a good example, Dr. Krishnan and his team of investigators included both qualitative and quantitative measures. So quantitative measures like pharmacy dispensation rates indicate that the intervention improved asthma management, right? And then the qualitative measures, such as survey responses, show that the intervention was no more effective than the control in improving outcomes. And this is something that was reported by the patients themselves who participated in the study. So we're able to kind of see through this study and through the variety of evidence, including qualitative evidence, we're able to see sort of a disconnect there. Other studies, for example, the BEAM study, there's clear quantitative data that the stress management class for parents was successful in increasing the quantitative measure of number of days without symptoms. But there was no qualitative measure of whether parents felt that their stress management classes were effective. So we're not really able to see the patient side of that treatment, even though we know that the intervention itself was effective. So there just is a little bit less information there, and there's a little bit less patient-centered information. So moving forward, patients' perceived effectiveness must be a key measure in determining the overall effectiveness of an intervention. Like, after all, isn't the goal of these interventions to make patients feel better? So if a patient feels better, their treatment is, if a patient feels better, then we know that the treatment is working. If the patient feels that their treatment is not working, they're going to be less likely to participate in the treatment. So, you know, a real recommendation is that to truly conduct patient-centered research, we must recognize the difference between demonstrated quantifiable effectiveness of an intervention and then the perceived effectiveness among the patients who are actually participating. And then our third and final policy recommendation, which is one that can be implemented sort of outside of the research realm, focuses on a very common intervention that has consistently shown to be effective in improving asthma-related health outcomes and just addressing inequities as a whole, and that is community health workers. So 3 of the studies discussed in this webinar focused on interventions that involved community health workers, or CHWs. And in all 3, the interventions were shown to be successful, both in reducing symptoms, that is more days without symptoms or less severe symptoms, and also in helping patients to manage their symptoms. So, you know, in the case of the Chicago plan, attending more doctor's appointments or filling more prescriptions. So thinking more about the Chicago plan that Dr. Krishnan mentioned, families who received home visits from CHWs after going to the emergency room took even more steps to manage their children's asthma. Some other examples in the G2P study, home visits from CHWs reduced asthma symptoms and improved patients' quality of life in every outcome that was measured. And then another example is the SAMBA study, where CHWs who were part of the SAMBA intervention program were effective in helping patients manage their asthma and control their symptoms in a home-based setting. So those of you who are familiar with CHWs, and I'm guessing that some of you may be, know that the sort of secret sauce that makes CHWs so effective is that they meet patients where they're at. They meet patients in their communities, and CHWs are often members of those same communities as their patients. So within these communities, CHWs are able to address social determinants that cause asthma, environmental remediation, help with just the care coordination, transportation are some examples. So they go beyond treatment in a clinical setting. So I will stop there, but to go a little bit more in depth on funding for asthma treatments that go beyond that clinical setting, I will turn it over to Stacy Chacker.
Hi, everybody. My name is Stacy Chacker, and I work at Health Resources in Action. And I don't have the silver bullet for sustainable financing, but I'm going to talk about what's going on broadly. And I'm talking specifically about the last point Emmett was talking about, which is community health workers. So you can switch to the next slide. Just historically, for folks on the phone to know, is that we at HRI have and are currently running a community home visiting asthma program. One was the New England Asthma Innovation Collaborative. It was funded by the Center for Medicaid and Medicare Innovation, and we served over 1,100 kids in collaboration with 9 sites. And we're currently working on a project for the New Jersey Asthma In-Home Pilot, which is funded by a private foundation in New Jersey, and we have 4 sites. While this intervention certainly showed positive improvements in terms of children and their health outcomes and attendance at school and parents and a reduction in ER usage, we did not show a statistically significant return on investment, which I think we actually thought we would. We were one of the first projects that had an evaluation based on both self-reported data and an economic analysis based on claims data. And the big lesson that we learned is that if you're doing an economic analysis based on claims data, you really need to have the race and ethnicity of that child. And that data was not available through the Medicaid data that we were able to get. So we'll move on to the next slide. So people that are working on this issue have found that it's a Sisyphean task. It's 1 step forward and 2 steps back. There's been a lot of efforts across the United States. There's a learning community about this, folks to get together to strategize and talk. Some of these that you're seeing up here are efforts, and some are currently going on. I want to say that Washington recently worked out a payment for their accountable communities of health, kind of like an ACO in Seattle-King County. So they are advancing community health workers for direct service, and they will be using a waiver through Medicaid to pay for it. It's not institutionalized across the state. I think they, as many places, are trying to demonstrate the intervention. But you can see that some people are using EPSDD, state plan amendments, waivers. Some are working to get payments through a medical managed care organization, and CHIP. So the next page, I'm going to talk a little bit more about this. Next slide, please. So there are some wins. Maryland has worked out a very innovative model to get coverage under CHIP, the Childhood Health Insurance Plan. They were able to leverage funding from their LED program for home visiting. I don't remember all the specifics, but they are funding boards of health for like a nurse and a community health worker that are serving a certain number of patients. And this has been institutionalized, taken a long time. It was through a state plan amendment. There are some sites that are using, going through their accountable care organization. So they are getting resources, and this is, I would say, a model that a lot of folks are using. One of the sites is the Pediatric Physicians Organization at Children's Hospital, where they have their ACOs paying for it. As I said before, Medicaid Managed Care in Philadelphia, they have a payment through the Medicaid Managed Care. I do have a warning statement about that, is that we have seen payments through Medicaid Managed Care come and go. I hope that's not the case for Philadelphia. But there have certainly been MMCOs that have been paying and that have either gone out of business or have stopped paying. Many places use community benefits. And actually I'm referring to New England here. Rutland Regional Hospital and Boston Children's have used community benefits. I forgot to say Boston Medical Center is actually currently working out a system through their ACO. Missouri HealthNet, which is Medicaid in Missouri, I believe has institutionalized a payment. And then others are trying and trying and trying. So California is working on a state plan amendment, and that's actually a document that they created to their Medi-Cal. North Carolina, I don't need to read all these, but actually you can see that there's different models through settlements, through designated block funds. There's no one size that fits all, and I think that many of the states are unsure about how to translate experiences that other states are using into their action. So the things are not always portable from one state to the other, and a challenge is that there's expertise and resources that exist, but it is still fragmented and somewhat ad hoc. Next slide. But we don't give up, so we're all working on how to get there. And I would say that these PICOR grants are really positive because the first thing is really to demonstrate it in your own marketplace, what you want to achieve. And I'm talking about community health workers, but whatever it is you're working on. Evaluate, again, I will really tout race and ethnicity and language data. And I will also say the Z code, which is a code for measuring, not everyone uses it, but social determinants of health and traumatic events in families' lives. And I would also say that whenever possible, you should be impacting the impact on a household. We're doing this in New Jersey where we're actually collecting data on not just the child who's the intervention child, but also the other children in the household. And that also includes the claims data, because we want to see what the impact is of learning what happens not just to the child, but to the family and their ability to manage chronic disease and their environment. So once you learn more about your program, you can improve and target, like who you might be serving. Are you serving someone with one ER visit or someone that's had 2 ER visits? You need to develop a business case. You need to know your audience and be concise and speak to what they're looking for. Actually, I have to say is that we found one Medicaid managed care organization that did not care about a comparison population that we had generated through claims data. They just wanted to hear about the impact on that one family. And I would say that whenever possible, address healthcare quality measures. We included in our analysis the HEDIS measure, the asthma medication ratio. We found that the intervention had a positive impact in terms of controller versus quick relief medication. Building relationships is really key. You need to educate, advocate, and activate, and you need to go back again. I think medical directors of health plans has a huge rate of turnover, but it's from the privacy officer to the case managers just really working on developing relationships. And also being understanding that there is no direct path. You've got to try multiple different things. You need to be flexible. You need to look for opportunities when they emerge. If there's a project going on and someone's got access to the governor's office or whatever it is, you just need to be flexible and willing to change your strategies. And one example of that is if there's like MMCOs are going through a procurement contracting process, is jump on that opportunity and make your case. The next slide. I just want to say really briefly, one of the reasons Rhode Island was like almost at the champagne moment, that's why there was champagne on there, and then there was a budget crisis in their state, so things happen. Partnerships are really key, and again, there's many pathways, but there's opportunities for funding in many different places, and keep your eyes open and collaborate with folks. The next slide. This is, I don't know what that funny line is on there. Anyway, this is an example from Rhode Island. They made an infographic business case based on our work from the New England Asthma Innovation Collaborative, as well as their work with the previous a previous cohort. And so I think when you're making your business cases, you want to make them as short as possible so that someone can digest it. You really want to be able to say, what is the what? Define the cost savings that you can. If you look to the left, eligible children in managed care, they really define the impact on Medicaid, so knowing your audience and what they care about. And then they included demonstrated outcomes. And the asthma program in Rhode Island developed this several years ago, and it's really gotten them into many doors. They participated in the 618 initiative, and I would say it's gotten them far. The next slide is another example. This is from Utah. And Utah defined their program and just made it really brief. They made what they were defining. I personally have a problem with this one, and I told them this, but their program cost, in my opinion, is quite low. One of my concerns is that when we see interventions that we are underselling community health workers, and they're considered, and I'm making my rabbit fingers here, they're considered a cheap resource or intervention. And I think that when people are building budgets, you need to keep in mind, A, having a fair wage for your community health workers, making sure that you're including the other costs in terms of supervision and support and supplies and all that other kind of stuff. The next slide. I just wanted to share some resources. These are asthma specific. You can link on them. Massachusetts has put together some great tools from a protocol manual and videos. The National Center for Healthy Housing, they have an online portal for building systems to sustain home-based asthma services. It includes some tools that myself and several others helped to develop from, and Families USA has a great impact estimator tool for asthma. And then the 618 initiative has evidence for the summary and control of asthma. So there's great tools out there to use, and I would encourage you to use them. And the next slide, I just want to say thank you for inviting me, and I was happy to participate. And I would say really keep in mind is do not undersell your services. I think it's really important that you're able to sustain your programs. Thank you so much.
All right, thank you, Stacy and Dr. Krishnan. We are now going into the Q&A. So if you have any questions, please make sure to put those in our chat box. We have a couple of minutes left, but we do have one question already. Thank you, Michael Bowman, for your question. And his question is, how do you deal with multi-ethnic or biracial patients, especially those that include Hispanic? They have a Hispanic and Black backgrounds. Dr. Krishnan or Emmett?
Sure. I mean, this is. I'm sorry. Go ahead, Emmett.
No, I'd be very interested to hear how you dealt with this, Doctor.
Yeah, so I think this is an important point that I think people are increasingly multiracial, multi-ethnic. We have to also recognize that just because somebody comes from a certain ethnicity doesn't mean that you can't communicate with them, sufficiently or just as well as anybody else in English. And I think part of this is maybe thinking very carefully about your target audience, conducting some planning activities, including contextual inquiry, where you go into neighborhoods, into emergency departments, clinics, homes, and understand what are the right communication assets you need to have, and what are tools that you could develop, and then to do some prototyping and piloting to be sure that information is being communicated in such a way that it's meaningful to your target audience. So I'm afraid the answer to your question is that it's not easy, but it's hard, but it's necessary. And I think one of the ways in which we were able to do that in Chicago, where we had both African American children as well as Latino children, is that we used a team that are experts in human-centered design to go do some field work and help us understand what are the right words and what are the right cultural contexts that are necessary in order to develop communication tools that work. So this is very possible, very doable, and I think this is something we need to incorporate as a best practice.
And I think just sort of the challenge in addressing or including multi-ethnic or biracial patients in research that challenge can potentially mask some additional disparities that might be experienced by multi-ethnic patients. So again, just to another plug for one of our policy recommendations is that whenever possible, to stratify data to include patients who might identify as biracial or multi-ethnic, so that in the event that they may experience even greater disparities, or in the event that an intervention is less effective for them, that data can be made available.
Other questions? Then we'll wrap up. We can give another minute just to see if anything else comes up, and we will be wrapping up pretty soon.
If I could add, this is Jerry Krishnan. Just as a high concept, I think people have all heard the quote, if you fail to plan, you plan to fail. In some ways, what we're really talking about are complex interventions that need to be developed with the end user in mind. And these things take longer to plan because you've got to take into account all the different inputs and all the needs. And so as you develop programs, make sure you're budgeting enough time to have relationships and to be able to do the work that you need, and to do some piloting before you go to full scale. There's no room to take something that was developed with my good colleagues in Seattle, Washington, and then plug it into urban Chicago. It just will fail because it's a different set of people, both in terms of clinicians and end users. So this is hard work, but one that I think the increasing number of teams are learning how to do.
Yeah. This is Stacy Chacker. I want to say that pilots also, even if you don't get to the gold star of sustainability from Medicaid, and first of all, there's a lot of avenues such as ACOs now, but they also really help to spread and build momentum in regions. People see what they're doing, and I've seen it across New England where there's been, certainly has been pickup across the region.
All right. So I think that's it. Dr. Krishnan and Stacy once again for all your wisdom and your input and participation in this. And I thank all attendees for your patience at the beginning and for your attention throughout. But this is the end for us. And if you want to know more about the Center on Health Equity Action, we have put our links there, and if you want to sign up for our Health Equity Action for Transformation Network, you can sign up by going to that Google Sheet there, and we send information on how to partner with us and any health equity related updates and news. So you can stay informed and with recent innovations and developments. But I think that's it for us. Thank you all once again, and have a lovely rest of your day.